Welcome to Spectrum Perspectives, real talk with parents, professionals, and autism advocates, with your host, Cindy Gellermini.
Hi, everyone. This is Cindy with another episode of Spectrum Perspectives. And today I have Dr. Stephen.Kolesk with us. Hi, doctor. How are you today? Thank you for being on the show.
Good. I'm excited to be here.
So you work at Woods, and I have interviewed a couple of people from Woods in the past, but we were speaking a couple of weeks ago, and I felt like you had a lot of information that would be great for my viewers to hear what you have to say. So we'll get into that. I always like to start in the beginning and back up a little bit, kind of get your background, just because I like people to understand who you are, where you came from, how you got into doing what you do now. So give us a little bit of background about how you got into the medical field and how you kind of ended up at Woods.
I'm a family doctor by trade. I'm certified by the American Board of Family Practice, and I've been a family doctor for over 40 years. So I've been around a long time. I started out in private practice, and we started practice in Mount Laurel, New Jersey, and me and my associate grew it to 6 physicians and 3 nurse practitioners by the time I left 25 years later. And then the hospital I was affiliated with in South Jersey, Virtua Memorial Hospital, asked me if I could do some administrative work there, and they asked me to run that hospital. So for 8 years, I ran a hospital, and then after that, was promoted to start some programs with physicians at corporate, which I did, and I started a couple companies and ran them, and then I decided I was going to retire, but I missed medicine so much that I continued to work, and I worked through a series of circumstances. I became the chief medical officer at Woods Services in Langhorne, Pennsylvania, which basically houses in schools individuals with intellectual and developmental disabilities. And I did that for 6 years, and then for the last several months, I've been here in Hamilton, New Jersey, and we're working on opening a practice for exclusively an integrated health practice for folks with intellectual and development disabilities in the walls of Robert Wood Johnson Hamilton Hospital. So that's where I am at the present time, and I'm very excited to be here.
So let's talk about Woods a little bit and about what kind of services they have available there and who do they treat. I know that Woods has day programs, I think, and residential, but there's also the medical facility there, and you have a bunch of different doctors there. And I know my friend brings her son to the dentist there.
Yes.
So do you do?
Yes, we have beside the day programs and the schools that you talked about, we have a residential program. We have programs for behavioral health, and we also have group homes that have started for those with medically complex issues and development disabilities. But I was the chief medical officer at the medical center at Woods, also called RL Health. RL stands for, I don't know what that stands for, but it stands for something. And it was a practice exclusively for those that resided in the community or in Woods, for those with development disabilities. So we were able to care for them. It houses not only primary care providers, physicians and nurse practitioners, but also houses, we have a optometrist, we have a podiatrist, we have an adult and pediatric neurologist, and there's also right next door to us is the Penn Dental Center, which is a dental center that exclusively cares for those with development disabilities, and there's a lot of reasons for that. So we're coordinated with that care, and the whole point of it is that it's integrated, so we can talk to each other about what is going on with an individual and why they need certain needs. And certainly after this call, I have to call the optometrist at Woods because there's a special patient that needs ophthalmological care, and it's going to be difficult to send him to a regular ophthalmologist. So we'll have this doctor see him there, and hopefully we'll be able to get his issue resolved.
Yeah, so that's something that we had talked about when I talked to you a couple of weeks ago, how that was my experience with my son, that I felt like I was bouncing back and forth like a ping pong ball. And there was, I guess, an orthopedist that wanted to do surgery on his feet. But then when I took him to a physiatrist, he says, well, of course he wants to do surgery. He's a surgeon. He doesn't need surgery. And I said, well, can you two just talk to each other? And I always wish, can we just have a center where all the doctors are in one place and they can all discuss a patient? Because one might be recommending something that maybe they don't necessarily really need.
Exactly. Yeah, so that is an extremely good point. I mean, one of the things that I find in having cared for the disabled, this is, of all the things I've done in my career, this is the most challenging yet the most rewarding. And not only challenging from caring for these individuals, because frequently if they're unable to speak or they are non-communicative, you have to figure out what's going on with them despite that. And sometimes, you know, there's a thing called diagnostic overshadowing. That's a principle of caring for the developmentally disabled, so that you assume, and providers assume, that a person is acting this way because of their disability. And that's not true. They still have medical problems. They still have psychiatric problems. And that isn't due to their disability. It's due because they're a person. Their disability is just hampering their ability to speak of what that is.
Mm-hmm.
And we try to get past that. There's a estimate that 40% of people that present, especially autistic people, present with behavioral issues, start acting out for whatever reason. It has nothing to do with behavior. It has to do with, there's a medical problem going on, and that medical problem is manifesting itself in their behavior. So you have to go past the behavior and find out what is going on from a medical point of view.
So
So
true. It could be a
that's
toothache.
very
It could be
interesting.
they could be constipated. They could have a bellyache, a toothache.
Right,
You don't know, and they can't explain it. They
right,
might just start
exactly.
hitting their head, and meanwhile it's because they have a toothache.
Yes. I took care of one woman that's an older person that had individual disability at Woods, and her issue was she would stop walking when she had a urinary tract infection.
Mm.
Just a simple thing. And everybody said she stopped walking, or a lot of people would say she stopped walking because she doesn't feel like walking anymore. It had nothing to do with not walking. It had to do with the fact that she had an infection and she just didn't feel good, and that was the issue. So we try to do that every time, and we try to make sure that we understand what's going on. It is a very complex issue, and as you said, we try to keep the folks, we try to keep a healthcare team we're together at Woods to try to say that these are the folks that take care of it, and neurological needs. We also have a great team of psychiatrists and nurse practitioner psychiatrists that take care of their behavioral health needs, and we frequently talk to them about what is going on. Um, uh, there's some documentation that perhaps 30% to 40% of people that have an intellectual disability are on some kind of psychiatric psychotropic med, they call it, and many of them are on multiple meds. So what we're trying to do is say, okay, if medicine has a tendency in general, and then, I'm not blaming my colleagues, but it's because a lot of them don't know better. But if you go on a medicine, you stay on it forever, ever and ever, and nobody takes them off of it because they're scared to take them off of it because they're thinking, well, they need it. Well, in a place where you care for the disabled, the intellectually disabled, you can try stopping a medicine to see if it's gonna affect them. If it does, you can put them back on it, or you can just stop it. But we have discussions with the psychiatrists all the time to say, we think this person is tired, or this person is sleeping more than they're normally, and it might be that the medicine you put them on a month ago. Can we change that? And that's the key thing. I think communication is the key.
For sure.
One of the things that I just like to say is that medicine in general, and I'm talking about my colleagues, and this is what I've discovered over the years, and I've discovered that most importantly over the last 5 to 6 years while I've been at Woods, is that most medicine does not understand or get or get training in taking care of the disabled, the intellectually disabled. They just don't know. And unfortunately, sometimes when somebody comes in and they're scared and they start acting out, or started having behaviors, all the provider wants to do is get them out of their office or get them out of the emergency room or get them out of the hospital, move them on without really finding out what's going on first. And that becomes a specific issue. One of the things that we're trying to do and moving forward is not only training our folks, but for instance, we have affiliation at Woods with many nurse practitioner programs with Temple, with Penn, with LaSalle, with Rowan, with different nurse practitioner schools, so that we can teach them about development and disability medicine and what's going on with that. I've been a family doctor for a long time. My medical school training was, many, many years ago. My training in intellectual disability was visiting a state of Connecticut hospital for the intellectually disabled for a half a day. That was all I got. So it's incredible. And even to this day, a lot of people don't understand what's going on. We have plenty of programs for instance, caring for pediatrics, for caring for geriatrics, for older folks. But we don't have programs for development disabled. I know Rowan University and Virtua has started a program including development disabled, and I speak to residents, and I speak to the National American Academy of Development Medicine and Disability yearly on what we can do to do this and to support education and knowledge about what's going on. You have to think about these individuals differently than you do in medicine. It's a different kettle of fish. It's a different approach. It's a different mindset. And it's a different way you approach the patient. And it's a different way you approach what you're trying to do.
For sure. Yeah, because that was my experience as well when Robbie, he had an infected wisdom tooth, I think. And when I called the oral surgeon, as soon as I said that he had autism, they refused to see him. And I just was stunned. I couldn't believe it. I had shared that with you.
Yes.
And you would think in this day and age, when 1 in 32 kids are being diagnosed with autism, it's off the charts, that they would begin to add that to medical school, at least give them a full day of training on autism, and how to see patients with autism. Because were you the one that told me? No, it was a different doctor that I had interviewed. And he said that when he went to medical school, they said in his entire career, he may come across one patient with autism. And now it's like on a daily basis.
Well, it's interesting, in my practice, way back when, 25 years ago, the fact is when somebody came in, we took care of a few group homes back then, and when they came in, it was our staff became, incensed because, so and so is in the waiting room making all these funny noises or making it because he's scared or she's scared, and we need to move them through, and rather than trying to say, okay, this is how we deal with it. And I know that at the Woods Medical Center and the medical center that we're trying to build here in Robert Wood Johnson Hamilton, the whole key is going to be how do you calm folks down with lighting, with people talking to them, and that's the key thing, that I find is that you just speak to them at their level. You can calm a lot of these folks down. It'll be okay. It's not hard to do that sometimes, but you can. You're still going to get swung at and things like that. But it's a lot easier to try to keep them calm and say, you don't have to do that. We can settle you down.
Mm-hmm. What about you had mentioned, the non-speaking. So let's go through the different departments. For instance, the dental there, right? If you have patients in there non-speaking. The reason I bring this up is because One time, my son, Robbie, when he was young, he was climbing up on a slide and he fell off and he fell on the ground. He fell on his head. And my husband rushed him to the hospital. And when they looked at him, they were asking Robbie questions. And my husband said, well, he can't speak. And they said, well, how am I supposed to know what's wrong with him if he can't answer me? Well, how would a pediatrician treat a baby? You know, a baby can't speak and
Exactly.
tell you. Like, I just thought that
Exactly.
my husband was so infuriated at that response, and it just shows a lack of understanding and really, and they don't care. It just seems that they don't care. That this is from a parent's
Yeah.
perspective,
Yeah.
right?
And that's unfortunately, and not trying to throw my colleagues under the bus, but that does happen. And unfortunately, I've had many intense discussions with emergency room doctors and emergency room nurses about what they need to do and what they actually did, and that you ignored the fact. And what we try to do, and what an important thing is to do, is we try to call ahead of time to say, okay, so and so is coming in, we think they have this or that, or write a note if they're a specialist to say, this is what I'm thinking, this is what I'm worried about, this is what we need to do. And the issue is, somebody else has got to be an advocate for that patient, like your husband was, or the family doctor, or us, and the development disability field, to say, okay, this is what you need to do, this is what we're worried about. How can we help that?
Mhm. But what do you do at Woods? That would be different than going to somewhere else. Like, how do you deal with your nonverbal patients? Like,
Well, we
how do you
well
treat
the
them?
interesting most of the residential homes have, a nursing supervisor, that has a nurse that oversees them. So we get information from the nurses, and we have access to the medical record and the electronic health record of each individual. So before they come in, we know that, say, Jane Doe is coming in from one of the houses. We can look up Jane Doe's record for the last month on um, on their record, and say, okay, what's happened? Did they have any seizures? Did they have any incidents? Did they have any injuries? Did they how did they see any other doctors? And that way you can get that. And frequently the nurse will help us get that information together. But if not, we can get it together ourselves. Takes a little time. Problem with this type of medicine is that it takes more time um, than than you do in a person population. I always argue with the powers that be, not at Woods, but at the other places, that this type of medicine requires more time and more effort than it does
Mhm. And more patience,
seeing a patient population that doesn't have
right?
intellectual disabilities. You can see patients if you have a cold and a fever, or if you have a cold and a fever, and you can see a patient in 10 minutes.
Right.
Well, not if you have ID or intellectual disability. It takes at least half an hour to figure out what's going on. You know, a cold could mean a cold and a fever could be anything from just a cold and a fever like everybody else has got, or it could be pneumonia, and that's the thing. And then there's a higher instance of pneumonia in this population. There's a higher instance of comorbidities in this person. Um, During the COVID pandemic, we there are some estimates that 40% of people that had intellectual disabilities in group homes died from COVID in some instances. We were lucky. We had our share of COVID, but we had no deaths. And we were very lucky because not only lucky, but we made sure that anybody that had COVID, we double checked on them. We saw them every day. We did, the nurses and the residential care staff would do oxygen levels on them, the pulse ox on their finger every day. And if they dropped it all, they went to the hospital. We had a couple people on ventilators for a few days, but nobody passed, back then. So we were very
So,
proud of that fact.
well, now what would you do though? For instance, like what I'm getting at, what's the different way that you would treat them? For instance, like if you go to an optometrist, you go to the eye doctor, and they can't speak, how do you treat a patient?
Well, again, you approach them differently. You know you get on their medical record, so you get the information from other folks rather than from the
Mhm.
patient. You know,
Mhm.
ask the patient.
Right.
You know, um the direct care staff will say he's sleeping more than normal, or he's getting up more at night than normal, or he's not sleeping more than normal, and whatever the case may be. And then you use that information, and then you ask different people, what's going on, and so you get information from a variety of sources rather than just the patient. You don't ask the patient because the patient freely can't tell you or won't tell you, won't be able to tell you, but you get it from other sources,
Mhm.
For instance, if they have a stomach pain, when's the last time they had a bowel movement? It could be 3 days ago, and if it's 3 days ago, then you can figure out whether they have a bad constipation problem, which is a huge issue, as you know, in
Yeah.
ID. Yeah,
Hmm. Yeah. Yeah. Well, I know over in the dentistry, they have several different methods that they can work. I was there and I walked through the place and I got the
right,
tour. I don't remember what it was, but I know that they had different ways of treating them depending on what their, you know, abilities were or
right,
anxiety level or whatever.
right. Yeah, the dental center is amazing. I work very closely when they were building it with Dr. Mark Hensfeld, who is the assistant dean and basically got specific interest um, in intellectual disability dentistry. And he's actually spoke with us last year when I went to the national conference about our partnership. But we'll talk to each other and we'll each other. And it's interesting. Just one incident. The last time I was there was Mark came over and said, this kid, he's 20. We call him kids to 25 years old,
Mhm.
but he was 25 years old, and he said he fell and he broke his front tooth and he cut his front lip, but he also is acting a little funny. You want to come over and just take a peek at him? Which I walked over and was able to look at him and talk to the nurse, talk to the caregiver, and it was just the fact that he was a little rattled from the fact that he had cut his lip a little bit and he broke his tooth, and he was fine from a neurological point of view, but we didn't have to do anything more. But those kinds of things. Similarly, uh, we had another patient that came in that had uh, taken a little slip and hit his head against the corner of a desk, knocked out his tooth. So we're standing there with his tooth and saying, "What do we do with this?" And I went over to the dental center and said, "What do I do now?" And they said, "I'll just send him over here and we'll take care of it." So that kind of thing.
Yeah. Now, you don't just treat the residents though. You treat people, outside patients can come in.
Yeah, we treat outside patients. We treat folks in the community. We also treat employees and people from the community that want to come see us. Not very many, we basically we will treat anybody that from the outside community. If somebody with an intellectual disability lives at home with their parents or with their family, they can come. They can bring them to us as well, and that's what we're going to plan at the Hamilton the Hamilton office that's going to open in August too. Yeah.
Yeah, so I'm very interested in the Hamilton one because one of the moms that comes to my all of my events through my foundation lives in Hamilton, and I think when I had talked to you, her mom was in that hospital. She was in RWJ for she was getting some nebulizer treatments. So I haven't been there, but I know of the location. So what specifically are you going to have at that location?
Well, we're building we call it the Woods Primary Care and Behavioral Health Integrated Center in association with RWJ Johnson, Barnabas Hamilton. And there's an office that's going to open up and is being renovated as we speak, right on the ground floor of the hospital, right near the administration offices. And it's pretty easy to get to. There's going to be lots of wayfinding to get there. And then we're going to have it designed and built to care for and staff for those to take care of the intellectually disabled. So we'll be able to see people from the community and to see people from, like right now I'm sitting at the Allies offices and Allies in New Jersey, also in Hamilton, and they have lots of group homes, and those folks can come to see us as well if they so desire, So
Mhm. So you'll have what type of doctors will be there?
Well, there'll be primary care doctors and there'll be psychiatrists to start with. And then we hope to get to the same kind of model that we have uh, uh, at Woods, which includes a podiatrist and a neurologist, perhaps half a day a week, and then maybe an orthopedist, although orthopedists don't like to come to other offices other than their own, but just saying.
Hmm.
And they and then the other specialists would be, like I said, an optometrist or an eye doctor. So we're trying to
Hmm.
work on that stuff. Yes.
Hmm.
Hmm.
Is this a hard sell for doctors? Because a lot of them are on Medicaid, no?
Well, that's true. It is a hard sell for most doctors because the reimbursement for these folks is not very good. And New Jersey Medicaid, unfortunately, is a very poor payer. And like I said, this spends a lot more time. You can spend an hour on a new patient and get paid 1/10 of what you get paid for a patient with non-intellectual disability with Aetna insurance or something like that. So unfortunately, a lot of doctors around this area just simply don't take Medicaid. They won't take it because they don't have it's not the reimbursement is not is not good. So
So like at Woods, for instance, no, that's Pennsylvania, so it's different. If somebody from New Jersey comes to Woods in Pennsylvania, how does that work with the insurance?
well, we've it took us a while to do this, but we finally got approved by New Jersey Medicaid, so we can see folks with New Jersey Medicaid. There's a lot of the residential folks that live at Woods are from New Jersey or from New York, so we both got New York Medicaid. And the specialist, especially the podiatrist, he's also takes New Jersey Medicaid, and the optometrist will, from my understanding, will take New Jersey Medicaid as far as I know. So we can send them over there if we need to. And Woods and Langhorne is only 20 minutes away from here, so it's not
Right.
that far.
But if they're younger, they would be under their parents' private insurance, though.
Right, exactly.
So we're only
And we're
talking
not we're
about
not
a
planning.
certain
Yeah,
age.
we're more interested in taking care of adults. We will take care of kids, but Children's Specialized Hospital, which is
Chop.
a division of Robert Johnson, is got an office for peds 2 miles down the road here, and
Oh,
I've met with them. They're wonderful people. They do wonderful work for kids with the development disabilities. So we're not trying to compete with them. We're just trying as what they call age out of a
yep.
pediatric program and they get older. And we've had requests for somebody like I've been taking care of this the one pediatrician said I've been taking care of this boy since he's been 4
Hmm.
and he's now 26. I'm a little uncomfortable taking care of him when he's 26.
Right.
But can you take him now? And we will. Yeah.
Yeah. Yeah. That's good to know. Okay.
Yep.
So, yeah, because my friend's son that goes, he's in his 20s too. So,
Right. Right.
um, okay. So
Yeah.
you're more interested in the adults.
That's a huge problem is that and this is could be considered a part political commentary, but New Jersey, the way New Jersey works is that if when you're a kid and have a disability, a lot of your services are covered. New Jersey Medicaid pays pretty well for all the services you need, be it teaching services, support services, devices, wheelchairs, crutches, whatever you need. They're paid for you. Once you become an adult, once you age out, and that's 21,
Hmm.
you're out of luck sometimes, and it becomes very, very difficult. And
Yep.
there's lots of advocacy going on to try to improve that, but it is very frustrating.
True. That's why I started my whole YouTube channel because after 21, I felt like everything fell off a cliff with my
Oh yeah,
son.
it does fall. You're absolutely right.
You
You're
know,
absolutely right.
they can go to school up until they're 21, and then there's nothing out there for them after
Right.
that. And
Exactly.
all of a sudden they lose. I mean, in school, he got speech and OT and, all of that. And then all of a sudden he's out of school and all of it's gone. And
Yep.
so
No, I
are they
agree.
expected to all of a sudden not be disabled anymore? Or they're not autistic anymore at
Yeah.
21? Is that,
Yep.
you know?
Yep. You're exactly right. This is Connecticut, but I have a niece who was born with a very significant genetic um, disability, and she can't speak. She's had multiple surgeries, multiple cranial surgeries, seizure disorder, doesn't articulate, can use a board for indicating what she wants, but other than that, but she says she's turning 20. And my brother is scared to death as what he's going to do when she ages out, because she's getting all these services now, and this is Connecticut, that are wonderful for her, and her mother's been a diehard advocate up there of what she needs. But when she turns 21, then, like you said, she's going to fall off the cliff, and she's not going to get those services anymore. And that's what's keeping her going and keeping her ahead of the curve, a little bit of her curve. Yeah. So I agree. The other thing that I just want to say is that two of the services that we will offer, and I'm going to start, I am available now to do them, is number one, beside opening this office won't open until like August of this year, because it's got to be built, and because it's in a hospital, it has to have all these approvals from the state and the Department of Health and all that stuff. And so it's going to take a while to get all that stuff approved. But two of the services that I'm going to offer before that is, number one, telehealth and telehealth services. So to be able to, not only telehealth services are available for psychiatry, will be available for psychiatry services, but also for medical services if you need them. And the second thing is house calls, that I can make house calls on folks and their group homes if they need that. And there's all kinds of ways to be able to do that. We're going to try to you have to limit that a little bit to your geographic area. So within a half an hour of where we are, but if you need a house call, we can do that. Now, in
That's
emergency,
huge.
we may not be able to get out there, but it'll be like for routine care, for screenings, and those kind of things. I think the thing that bothers, one of the things that bothers me the most about caring for these individuals is the rate of getting through their screenings for their care. Simple things like immunizations and pap smears in women, and mammograms in women, and those kinds of things are very, very marginal in this folks, because of their of their of the medical system's ignorance of that. So, probably less than 30% of people get the appropriate screenings that they need. Colonoscopies is another one. And then we struggle with that at Woods as well. And even we tried to get one of the university systems, whose name I won't mention, we try to get their mammogram van to Woods to be able to do mammograms on our folks that their appropriate age. And they found out what the New Jersey Medicaid rate was for that, and they said we can't afford it, so we're not going to do it. So we struggle with that. A lot of folks, not a lot of folks, but a good percentage of folks, mammograms are not pleasant to begin with, and they're somewhat painful, and in person with the disability becomes a scary place.
Sure.
So we're trying to do ultrasounds instead, and see if that can do some screening. We have some ability to do that. We have the current doctor at the Medical Center of Woods. She does a lot of screenings. It's difficult to do sometimes, but you can get that done. And just things like simple lab work. There's a higher instance of high cholesterol in these folks. There's a higher instance of obesity in these folks. There's a high instance of diabetes in these folks. And just doing blood work can be very, very difficult at times, and very, very, you can try 3 or 4 times to get blood work, and they won't sit still. And that's okay. You have to pursue it. And then we try to get them to do that,
Mm-hmm.
It's part of the project, but you sometimes have to see them where they are. So I've examined people when they're lying on the floor because they refuse to get up, and I get down on the floor with them and lie down on the floor with them. Difficult for me to get up too, but we do it. And then I've seen our I've seen some of our nurse practitioners chasing people down the hall when they're running away from them to try to listen to their lungs,
Right,
those kinds of things. So we try to accommodate what we need to do for them as best possible.
right. So I would imagine that the staff probably doesn't get paid as much as it would do in a regular facility since it's the because of the whole Medicaid issue. I think it's something that you have to be
Yeah, I think
feel
it's not.
have a
Well,
passion for or a calling.
you have to have a passion for it, and I think as far as getting paid is concerned, they get paid the normal rate. We pay a little bit. I think they get paid a little bit better. We get paid a little bit better than they do that, and I think Woods, in its wisdom, considers it a lost leader. That they're never going to. It's never going to be a profitable medical center. They're hoping to break even, and that's what we're hoping for at this place is to break even from a financial point of view, but. I'm not a finance guy, so I let others worry about that stuff,
Right. That's not your department, right?
It's my department, exactly.
Okay, good.
Good.
Yeah, because I find that one of my sermons that I preach all the time is that in a lot of group homes and day programs and stuff, the staff is very unqualified because it's a minimum
Yes,
wage job and they need to
yes,
pay better so that you have better qualified people.
yes. You're right. You're absolutely right. I amen to that. Yes,
Yeah. Yeah. So it's good to know that it's just because it's a Medicaid facility doesn't mean that it's people that are, not necessarily that good at what they do. It sounds like
right,
they,
right. One thing about Woods, as far as the direct care staff and the direct support personnel that they call them
Mhm,
DSPs, for short, direct support personnel,
mhm,
people that they care for them on a daily basis and make sure that they get to where they're supposed to be and their activities of daily living. They eat when they're supposed to. They toilet when they're supposed to. All that stuff. There's an extensive training facility, an extensive training program that's been developed there that trains these folks and supports them in all the things they need to know and help them to know what they need to do. It's not it's not always perfect, but they do a pretty good job there. They do a very
mhm.
good job there.
Yeah.
You know.
I think I
Yeah.
read something on the website too about they'll deal with people that have the more like behaviors and property destruction and things like that. Like when those are the more. I have a friend that's describes her son, and he's
Yes.
been in and out of different facilities, but it all started with the property destruction and things like that. He's got
Yep.
more behaviors that not everybody wants to deal with.
Yep.
Um, but it sounds like that's something that they're not afraid of at Woods. And when I was there, they showed me these blue mats that they use. Like they're like have this, what do they
They're
call that?
called Ukuro. Ukuro. Yeah.
Yeah, yeah, it's like a
Yes.
hands-off thing, but can you explain that
Yep.
a little bit?
Well, what Ukuro is a method. Um, we there's a law in this type of care that you can't restrain people.
Mhm.
So in any way possible. I'm not talking about just tying them down, but that you used to be able to do. They used to be able to do that, or used to do that all the time, and it was not good. It made things worse. And then even if somebody starts acting out and you grab them the wrong way and hold them down, that's considered restraint. So they have this things called Akura, which are sort of like pads, the soft foam pads that you surround the person in. And if the person is angry and upset and wants to, like you said, property destruct, they can punch at these pads all they want and they'll tire themselves out and they won't get hurt. They won't hurt any of the individuals that are around them, and they'll whatever is bothering them will get out of their system, and then they'll settle down, and then you can deal with them on a communicative basis.
Hmm. Hmm.
So it is really cool. All the entire medical center staff, including myself, was trained in the Kura method. So occasionally we haven't had to use it at Woods, but we've had to use it a couple of times where somebody gets unruly because they need to have an exam and they get upset about that, and
Well,
we
yeah, I mean, that's something that's going to, I mean, I personally have a fear of needles, and so I get anxiety, so I'm somebody
yes,
that I needed a root canal, and I said, "No, you're going to put me out. There's no way. I have to be put out because I can't." So, and I can only imagine that on top of not being able to communicate and all the other issues that the kids with autism have with the anxiety. It's
Yes,
my anxiety
exactly.
times 100. So, as a matter of fact, I went. He sent me to an oral surgeon, and I felt that he did not have a great bedside manner. And I had mentioned to him, I said, "Look, I don't do well with needles." And he was basically like, "Oh, well, just get over it. You'll be fine." And I got up and walked out of the office. So I'm
Yeah,
not,
that's right.
no.
That's
And I
ridiculous.
had to go to somebody else. So, and I can just imagine somebody like that is certainly not going to have any patience with my son. So,
Exactly, exactly.
and I
And
can
that's what
imagine
happens.
them there, we'll call it a behavior, but it's, to me, being in a medical setting where they say, "Oh, well, we're going to stick a needle and take your blood or whatever," that's, you're going to get
Yeah,
you're going
exactly.
to get
Yeah,
a
right.
reaction.
Exactly.
You better watch out you don't get
Uh,
smacked in the middle of it. So, yeah.
Exactly. Exactly.
So I'm glad to hear about that method.
Yeah, exactly. It's really it's very cool actually. And I'll be perfectly honest. I was skeptical about it at first, but it works like a charm. It's amazing.
Mhm. Good.
I was like,
Good.
oh, what is this? But that's okay. Yeah, it works.
Yeah. Um, Go back to the house calls because I remember that you had mentioned that to me, which is amazing to me that you do house calls. So, what is this, Pennsylvania or New Jersey or both? It just, and is it only
It could
you
be
or are there other
Pennsylvania.
doctors that
It's
do
going to
it?
be New Jersey, but I'm licensed in both Pennsylvania and New Jersey, so I can do either. But it's going to be mainly New Jersey for this facility here. And
Mhm.
if they're within a half an hour of the facility, or I live in most southern New Jersey, in Delran, New Jersey, which is just north of Camden.
Mhm.
I'll be able to do house calls, and the providers will be able to do house calls as necessary. And Actually, our providers at Woods actually do house calls at some of our group homes for our more medically complex people.
Sure.
Um, Now, we'll do that. In order to do that, you have to prove that the person can't get to you, from a medical
Mhm.
point of view. And there's ways of doing that, but in this population, it's sort of easy to be able to do that. But house calls are a wonderful method to find out what's going on, what's surrounding them. You can look at their meds and find out, especially in this population, not so much because a lot of them have people that give them their meds, but if they're independent, make sure the meds they're taking are the meds they're supposed to be taking,
Yep.
what they call medication reconciliation. We can do polypharmacy where we if they're on five different types of medicine, do you need five medicines or can you cut them back down to three? And then you can work on that. And then you can find out if there's hazards at home, if there's tripping hazards or falling hazards or dangerous hazards or something that doesn't look right. So
Mhm.
it really, and then you see what their living situation is like. So you understand what's going on and what their support staff is like and what is happening. So I find house calls very rewarding. I did one of my after I retired from virtual, I did house calls on the elderly for a year in New Jersey. It was amazing, and sometime we get a chance, I'll tell you some stories about that. But I could write a book on some of the things that happen in some of the house calls. But it is an amazing thing. You you'd go in and you'd say, okay, let me see your medication. They pull out a plastic baggie and they say, they take a red one and a white one and a blue one. And I say, well, what are they? And they, I don't know.
Oh no.
So you'd sit there with your iPhone, and luckily the iPhone has a med recognition thing on it. So my iPhone, I would say, okay, that's this and that's that. Why are you taking that medicine? By the way, have you ever heard the drug omeprazole? Omeprazole is a medicine for GERD, and it's for stomach problems, for dyspepsia.
Okay.
It's a very common drug that people are on. It's basically it doesn't allow the stomach to secrete acid, and a lot of people use it for reflux. And a lot of folks with intellectual disability have reflux for a variety of reasons, but
Right.
that's a major complaint. Well, once you're on omeprazole, you're always on omeprazole forever and ever and ever. So I always try to find out, why were you on it? What's do you really need it? And if you don't need it, if you don't know either of those questions or nobody knows the answer to the questions, take it off. And if they get symptoms again, we put them back on it. It's, so,
Right. Right.
yeah.
Right.
So house calls are an amazing way to find out what is actually going on,
Yeah.
with people. Yeah, it is.
Yeah. Oh, yeah. And you see their whole environment and everything,
You see their whole environment, what's happening to them, who their support is, who's taking care of them, who's not taking care of, are they being taken care of properly? If you,
Yeah.
so it's very, very cool. Yeah.
Yeah. Yeah. That's such a lost art, lost thing of the past,
Yeah. It should be, you know, I'm old enough. I remember when I was a kid, the pediatricians used to come to my office, my house, and give me my immunizations and my shots and
Wow.
I remember I had measles as a kid, and
Hmm.
he came by every day for 3 days to make sure I was okay.
Wow.
Mm,
That's great.
Yep.
Yes. I remember when the milk bottles used to be delivered in the glass.
Yeah. I did that too as a kid.
There's people that still do
Because
it. There's a company that still
yeah,
delivers.
I used to do that. I used to run milk. We used to call it.
Really?
Yep.
Oh, that's funny.
Yep. Long time ago.
All right. Well, let's give your contact information in case people need to come see you. They want to know more. How can they reach you?
Yeah, the best place to reach me is my email is Stephen Stephen Kolesk Kolesk
Hmm.
at woods.org.
Hmm. Okay.
And let me get you the phone number. They just gave a new phone number where you can call, so I got to look that up because I forget it. The over perfect. The best number is to reach me is 215-532-3164.
Okay. And I didn't ask you. Now you said that you had retired, and then you ended up going to work for Woods. What made you want to go work for Woods? Just because you wanted to stay in the medical field, or like did you have any interest in working with this population, or?
Well, like I said, I have a niece that has intellectual disability, and I see the struggle she went through from a medical point of view, and I saw the struggle she went through when she went to the hospital and went and needed care. And um, I spent some time arguing with various specialists at Yale and at Yale Children's Hospital and Hartford Children's Hospital over care over the years, and I just felt that this was an opportunity to be able to care for folks who needed it more than most,
Mhm.
and who needed somebody to look after them. Um, like you did with Robbie, there's, you almost got to be like a parent to these folks, and from a medical point of view, and say, okay, what do they need? I'm struggling right now with somebody that needs ophthalmological care, and the ophthalmologist is giving a hard time to them, and I'm just saying, okay, let's get them to somebody who's going to take care of them, and that needs this type of care. So I just think it's good work. A friend of mine told me it's God's work. I'm not sure I would go to that extreme, but it is good work that is desperately needed, and it's an area of the population that, frankly, of the medical profession that, frankly, has been lost and needs reviving. So that's really why I went into it, because I like it. I really do.
Yeah. I tell you, I would feel so much better if I knew that I had you on my side to kind of advocate for my son, because you know the field, where I
Yes.
felt as a parent, I know nothing about the medical field. I'm completely
Right.
lost,
Exactly.
I need, you need somebody on your side that knows how to navigate the system
Yes.
and understands what they're talking about.
Exactly. And remind them of what we're doing here. Exactly. Sometimes I know with
Yeah.
my niece, I would remind the specialists, what are you doing? You know,
Hmm. Yeah.
and why are you doing that for? That doesn't make any sense to me at all.
Right.
You know,
Right.
and let's get back to what's going on here. So that's
Right.
good.
Right.
Yep.
And I
Yep.
heard somebody recently make a comment about, um, you don't want to give any names or anything, but the medical facility where the pediatrician is, near me, it's just a big, huge facility, and they sort of just bang it in and bang it out. It's like you said, it's
Yep.
like they come in with the sniffles and the flu, and a fever, and it's like you can see them in 10 minutes and boom, 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 and they don't really take the time, it just seems to be just sort of a business, where, so it's
Yes.
just nice to know that there's a human side here of people that actually care and take time
Yep.
and
Yep.
are even willing to go to the house. That's amazing to me. So
Yep.
thank you for what you do, for your
Good. I
good work.
appreciate that. I appreciate it. Thank you. It is good work, and thank you for everything you did. You're an advocate of what we're trying to do, and we need more people like you to be able to teach us all. Teach us and our colleagues what this really means and what this really achieves. So appreciate your work too.
Yeah, thank you. Thank you. All right. Well,
Okay.
thank you for being here. I appreciate it. Let me know when the place opens in August, and so that I can
Mhm.
send people there, send people that I know.
Okay. I will let you know, Cindy.
Okay.
Thank you.
All right, great. All right. Have a good day.
Take
Thanks.
care.
All right,
Bye-bye.
bye-bye.
Thank you.
That's it for today's episode. I hope you enjoyed listening and it helped you gain a new perspective. To learn more about our children's book series, Robbie's World and His Spectrum of Adventures, or to learn more about what we do at Robbie's World Foundation, simply visit our website at robbiesworldbook.com.
Thank you for joining us today. Be sure to join us again on our next episode of Spectrum Perspectives.